Hi, good evening to one and all. I would like to welcome you for the second episode of FCPI podcast series. Thank you all for the huge response that we have got for the first episode of FCPI podcast series. The FCPI podcast is an initiative to discuss different aspects of clinical pharmacy, helping participants understand a clinical pharmacist professional journey. This is Dr. Nischala, clinical pharmacist, Continental Hospitals, and a member of FCPI Forum. I'll be the host for today's podcast, which is about unleashing transplant clinical pharmacist roles in India. Today, we have two guests with us. I would be honored to invite the guest for today's episode, Dr. Sudhindran, clinical professor and chief transplant surgeon, Department of GI Surgery and Solid Organ Transplantation, Amrita Institute of Medical Sciences, Faridabad. He is the hi sir, hi. Good evening, sir. I hope you're doing well.
It's my honor and pleasure to be here. Thank you very much.
Thank you, sir. Thank you. Thank you for being here with us to share the insights about the transplant clinical pharmacist. Sir is the first liver transplant surgeon in Kerala and a well-known expert in liver transplants. He has completed over 1,400 liver transplants, mostly live donor transplants. He also has expertise in pancreas transplant as well as small bowel transplants. He had completed his MBBS and MS from Trivandrum Medical College. Later, sir is trained in vascular surgery and solid organ transplantation from UK. Now, let me invite our second guest of honor, Dr. Harita Rajakrishnan, who had graduated PharmD in 2022. She worked as a clinical pharmacist in medical oncology for 6 months, and from where her interest has driven towards transplant, and started working as clinical pharmacist in Department of GI Surgery and Solid Organ Transplantation.
Hi,
I welcome you both.
Thank you.
Thank you. Thank you for having here. It's time to get some deeper insights from our expert guests with this today's episode. Let's talk about the ID transplant, the transplant clinical pharmacist, which we haven't seen in many of the hospitals being a clinical pharmacist in transplant. So we would like to know from the clinical pharmacist perspective and the surgeon's perspective how the clinical pharmacist can add on roles to the treatment part or for a better patient care. So coming to Dr. Harita, so how my journey as a PharmD graduate, I have chosen a PharmD. I had different reasons to join PharmD. Likewise, many people we have heard that they have joined PharmD because they didn't get an option to join MBBS. So how did it happen to you to join as a PharmD and working as a clinical pharmacist?
Hi to all. Thank you so much, Nischala, for that wonderful introduction, first of all. And coming to the question, I think that question, I think the answer to that is quite similar for all of us, because as you rightly said, it's with the ambition of being an MBBS doctor that we somehow come and end up in being a PharmD or clinical pharmacist. So we have this ambition of being a doctor, like 24/7. We want to be working towards the patient care and etc. So the story is quite similar for me as well. So I had the ambition of being a doctor, and then I did my entrance and everything. I tried getting that, and then at some point, at a certain point, I knew that okay, this is not my calling. Maybe I have chosen a wrong path, and maybe I have to do something else. But I mean, I was quite sure that I had to do something in the medical field itself. It's not like engineering or anything else that I wanted. I had to do something in the medical field itself. And that's how I just came to know about this PharmD. And there are like three main points that drag you towards the PharmD career. The first thing is obviously it's a 6-year course, and you're being a clinical pharmacist here. It's not just a regular pharmacist you see in the medical shops or anything. You're doing a job along with the doctors. You're assisting them in choosing the right drug, and you're helping them prescribe medication. So all these things, it just maybe give a click. Okay, that's a nice thing to do. And the second thing is obviously it's a 6-year course, and by the end of your course you get this doctorate thing. that's there in everyone's mind. That's definitely there. We can't
Yes.
just deny it. It's definitely there. And then the third and most important point is that you have opportunities abroad. And then in abroad, the clinical pharmacists, they are the ones who actually prescribe the medications, and the doctors and the physicians, they're mainly involved in diagnosis and etc. So the clinical pharmacists, they are involved in the counseling point, and they're involved in prescribing the drugs. So all these points, they just make you maybe just makes you choose the career somehow. So that's the same thing that happened to me as well. So that's how I chose this path. And I have till point I have never regretted my choice as being a clinical pharmacist or having chosen the career, because it has made a lot of difference in the way, not just as a career, not just as being a clinical pharmacist, or not just being from the job point of view, but as a person also, it has made a lot of difference. A lot of things you learn over the course, and a lot of things you actually end up doing. So that's how my family journey started. I think it's the same story, same old story that all of you must have heard. Yeah.
Yeah. So as Dr. Harita has mentioned about the opportunities for the clinical pharmacist abroad, so I want to ask this question to Dr. Sudhindran. So, sir, you had been working in UK and you have come over to India. So, can you tell us how are the opportunities for the clinical pharmacist, and how is it over there in UK, or what do you see that like? How is there a difference from UK when compared to India?
Yeah, so having worked in India for a long time, and then when I went to UK and started working there, it was like a completely different, book opening for me with the clinical pharmacist. So every ward has a clinical pharmacist. I think, as far as I can remember, I think it was more ward-based than specialty-based, I think. So every drug that we write, every medicine that we write, I think 2 minutes, 3 minutes later, the person, the clinical pharmacist, used to come and tell you, "Doctor, I'm sorry, your dose is wrong, your this is wrong, your word is wrong." And then slowly I got used to them. And then it was like they were doing all the drug sheets. They were doing a lot of, they had the freedom, as they have now here, write on the drug sheets and change it and tell us the mistake that we had. So this was, I'm talking about in 1993, 1994. So at that time, they played so much of an important role there. And to the point, so initially, when you do your MBBS and MS, you're supposed to, the doctor is supposed to remember all the doses, refer something and write your dose. And you're like, oh my God, you're not supposed to do that. But then when you went to UK, I learned, no, you have to refer and check and double check and make sure that your dose is right. And that was again a revelation to me there. So, because who can remember all these doses? You can't. So because patients also used to have that feeling, the doctor is looking at the book and prescribing. But now all that has changed here.
Yes.
So the role of the clinical pharmacist is really huge there. And I'm glad to see that the same thing is happening in India as well. We are going that in the same route. At least in Amrita, I think I find that a lot has changed since then.
Definitely, sir. So, adding to that, from the receiving end, is there any difference that you've observed when in abroad, how the consultant receive when there are any interventions made by the clinical pharmacist when compared to India?
Definitely, because see, the clinical pharmacists they're the dependable lot, and they've been there for a long time. So more often the consultants will ask them rather than ask the registrar, or that's what senior registrar, that's what I was. So they discuss, so much so that even I was so much used to sort of asking them for whatever is the medication. Actually, what do you do for this? Even what is the antibiotic that you actually prescribe for this? So it was standard there for that. And it made a huge difference because it takes so much stress off the physicians as well, because a very, very important part of the whole, the thing in the medical ward, isn't it? And when that's it's a significant, it takes a lot of concentration, a lot of effort. And when that is actually, it's given to another person, that division, it makes the whole efficiency a lot better. No doubt about that.
Definitely. So this is to Dr. Harita. If you can give me the Indian scenario, because you are working into the transplant where many people have not explored this area. So how is it for you to make some kind of intervention, or how to deliver it to the consultants? What is the acceptance rate? So can you tell us more about these things?
Sure, sure. So it's not basically just transplant that I'm looking into. So like I'm basically a clinical pharmacist who's posted in Department of GI surgery and transplant. So we have to look into all the cases, all the GI cases and transplant along with it. So here, if you ask me the acceptance rate, so first thing that I need to mention here is that here in this department, they have been working with clinical pharmacists for a really long time now. I think since Sir has joined, Sir has already taken up a clinical pharmacist. If I'm right, can you correct me, Sir, if I'm wrong? I think you have taken up a clinical pharmacist since you joined here from UK, isn't it?
Not really, but then yeah, like couple of 2-3 years later, I think there was somebody joined. I think, yeah.
Yeah.
I had to push a lot. Yeah.
It has been like a long time that Sir had been in
Yeah.
contact with the clinical pharmacists. It is like a continuous team that has been continued.
Yeah, exactly. So Sir has been in touch with the clinical pharmacist since the moment he actually could somehow press the admin departments to make sure that a clinical pharmacist has joined here in the department. So actually it was easier for me because since I like already Sir has worked with 2 or 3 clinical pharmacists before me. So since then itself, so I mean the department is like they ask the clinical pharmacist for a lot of medication error doubts or anything, whatever that is related to medications, they actually ask the clinical pharmacist itself. And if at all we have any interventions, especially the transplant patients, the medications are quite intense. They have a lot of medications, like there are immunosuppressants, there are antibiotics, antifungal. So it's like quite extensive. So they do ask us for our advice as well, our opinions as well. And yeah, and the acceptance rate is, I mean, I don't know, it's like I can't complain about it because they definitely they do consider our opinions and our advices as well. But I think you should ask Sir first this question because since Sir has a lot of experience with CPs, so I think you need to go back a little on the history there with Sir. I think he will explain it way but much better than I can.
Yes, sir. Can you just add on a few points, like how it has started adding a clinical pharmacist to your team? Like getting an idea to have a clinical pharmacist on your team is only the biggest thing, because surgeons usually we haven't seen anywhere that they have clinical pharmacists on board, work along by their team. So how is that, and how is the journey of having a clinical pharmacist during the initial years, and till now, like till date, what is the change that you have observed from the services that they have provided?
Thank you. Yeah, it's been a long journey, as Harita said. So initially when I came, I mean, we didn't have a clinical pharmacist at all. But then one thing we had posting from M-Pharm students, particularly do some sort of a research work with us. So I remember one of the first M-Pharm students, I think Shamina, her name was. So she came and she wanted to do something in GI surgery because I was in transplantation. So I said, why don't you look at the immunosuppression medications? And how does it actually fare with the standard original products compared to generic products that we have in India? And that is what we looked at that time. How does the generic products compare with the original products? And because we have tacrolimus levels, we know how each drugs work. And we were surprised and happy that our Indian drugs were actually very good. And we published that because Dr. Manuel, who was actually the principal of the pharmacy college, is very, very particular in publications. And we managed to publish that in an Indian journal. But nevertheless, that publication actually got one of the best paper awards in one of our major conferences. And we were very proud of that. Subsequently, every year, we had M-Pharm students coming in and doing some sort of a thesis. And then it became then I was like, really missing the clinical pharmacy from UK because we were back to the same original thing. We had to go and look at the drugs, etc., etc. So many things were there. And I think the first one was Anish was the first clinical pharmacist actually joined the department because he started as an internship. That time, Dr. Emmanuel, the principal, he wanted the interns to come and join the department. So I can't remember how long the posting was, maybe 1 month, 2 months, something like that. Can't remember. But the first person who finished the internship, he was really interested in our this thing, and he said, "Can we join as a clinical pharmacist?" And that is how I think that time there was maybe in medical oncology. I cannot remember, but it was not a standard post at all. But so I really had to fight with the administrator. Say, this is very important. It's transplant. We can't risk making a mistake in the dosing, etc., etc. And somehow they found this temporary post for 1 year for this gentleman, and that's how it started. And then we found him very useful, and he got his junior to come and join when he left, and that is Abhijit. So Abhijit is also very good. He was very proactive, and then he started being with me in the outpatient department, and being friendly with the patients and talking to them, and so not only was he going to the inpatients and taking all the drugs and tacrolimus levels and letting me know all those things, he started coming in the OP as well. And the person after that was Nafia. I mean, Nafia was unbelievably proactive because she actually was sort of it was like she wanted to overlap with Abhijit when Abhijit left. Abhijit got a post in Australia, and so before going, she wanted to come and see how the job was, and she actually almost stayed for about 4 or 5 months without any pay, to get into this job. And then subsequently she made a whole lot of changes in the sense, the protocol was made, and then by the time she left, everybody had almost got used to this clinical pharmacist, and even the patients, they were actually ringing the clinical pharmacist. So previously it used to be the coordinator used to take all the calls from the transplant patients. So when the transplant patient has got a cough, they'll ring the coordinator will ring me, then I'll ring the coordinator back, and the coordinator. So like a three-way circle used to go. But once she came, she was taking all the calls, and the number of calls I used to get, they came down to almost 90%. And then of course after that was Harita, and she has been. I shouldn't say in front of her, but then I have to say she has been. I mean, she has made a whole lot of changes in the sense people never hardly ever ring me at all. I mean, she's very friendly with the patients, and they're comfortable with her. In the sense, sometimes they feel that they can't be too friendly with the doctor. So to the points, they don't talk about just the drugs. I think they talk about their personal life, many things, all their problems, etc. So it's gone to that sort of a level. So now, and as she was saying, even the MCH PG, who are like post MS post, they're quite senior doctors, surgeons, I mean, and for them, he's indispensable. I mean, every single thing they just ask her, what. So if okay, I've got Klebsiella pneumonia. Arita, what antibiotic should I? So that's the way it has become now. So and become an integral part of the unit. So I think, and that journey has been long, but I think it's a very, very, very useful journey. And so I think you're up there, right there. With
Now
the
you know
physicians.
how stressful it was for me to take up this job. I had to step into a huge shoe there because clinical pharmacist role was well established in the department, and then I was coming up here, and for me
Trying
it
to
was
fit
like,
in.
yeah, trying to fit in because as sir rightly said, all the MCG PGs, even including the consultants, everyone, they just ask this clinical pharmacist about the dosages and everything, each and everything. They just want to make sure, they just want to double check at least. Okay, is this right or wrong? So for this patient, should I be doing this? Okay, actually, on a later stage, they even start asking, okay, so this transplant patient has got admitted. So what am I supposed to do now? So what is what is supposed to be the follow-up and etc. So it was like a huge shoe I had to fill in. So it was quite stressful. So that was one of the challenges I had as a transplant clinical pharmacist.
So, we were talking about the OPDs and interaction with the patients. So, how is it like many of the specializations, like if we look into ID clinical pharmacist, the clinical pharmacist will not get to interact much with the patients. So, they'll have a lot of interaction that we have with the ID specialist, and then we give our interventions to the consultants. So it is in between the consultants and the healthcare professionals only, if I have to say. So there is not much of interaction that we could get with the patient. So like working in a transplant unit and getting that interaction with the patients, if they call in middle of the day and then you get a call if they have some kind of query, and how are you handling if there is anything that you are stuck somewhere? Like, how are you are you calling the consultant in the middle of the conversation and getting the answers, or how is it? How are you dealing? Are there any difficulties?
Yeah, so for this, actually, I didn't have much of an issue here. That's mainly because my first posting as a PharmD intern was in GI surgery itself. So that's how it all started. So during my internship itself, I mean, that time Nafia, as I said, Nafia was a clinical pharmacist in GI surgery. So I was like getting trained under her. And then she had to take an emergency leave for like 2 weeks. And then sir and she just asked me to, like, can you just handle the on-call, because she had to go abroad. So it was not I mean, she was not able to take up the on-call phones. So they just entrusted with me the responsibility of attending the on-call phones, and also the attending the OPD sessions. So during our internship, in actually, I mean, it's like we just have to attend the ward rounds. But then because of this particular situation, I had to attend OPD as well. So that's actually when I understood, okay, so there is more to it. It's not just about attending rounds, not just about reconciling or, just attending the rounds and maybe, okay, there's an error here, or just doing the auditing works. There's actually more to it. And it's not that just the doctors or the PGs, it's not their job alone to know the patient history, to talk to them. It's not exactly their job alone. So all we do while reconciling is, okay, so what are the past medications you're taking? What are the regular medications? Oh, okay, fine. Then we just end our job there. But it's not just about, knowing the medications. You need to know a lot about them. Maybe their setting, how they live, and how the financial status is. Are they able to afford the medications? A lot of things that we have to look into. So that's how, that's something that I learned when I started attending the OPD sessions. So starting from how do you actually end up with the diagnosis of the patient? How do you choose an appropriate immunosuppressant for the patient? Because we know there are a lot of immunosuppressants out there. It's not just one, 3 to 4, a lot of medications are there. So for each patient, it actually varies. So how you choose it? So when you're in the inpatient, it's not necessarily that during the ward rounds, you need to know that, okay, this patient is on this remark, I don't know. But during the OPD sessions, you actually come to know why this patient actually got admitted. What is the kind of toxicity that we are looking into? How do we adjust the levels? I mean, based on the levels of tacrolimus, how do we adjust the dose? Or what are the side effects that we need to look into? Even the minor to minor toxicities that we may not actually know, but that patient is manifesting, and that's something only the consultants know because they have experience in dealing with those patients. So a lot of things that you learn during your OPD sessions. So that's something that I learned during that internship setting. And then that's how I got this on-call phone as well. So during that time, it was a very stressful situation. Those 2 weeks were a whole stressful situation because I used to get the patient calls and they used to tell me, okay, I have this issue, so what I'm supposed to do? And I was like, okay, just give me a minute, I'll ring you back. And then I used to text the clinical pharmacist, Nafi, and I used to ask, okay, this patient is calling with this complaint, what I'm supposed to do? And she's like, very coolly, she used to just give me an answer. I didn't even have to ask Sudhindran sir or any other consultants for that matter, because she had an answer for that. Even if the patient asked me for some medications, I'll be like, okay, I'll ring you back. So all the time I had to give the same answer. I'll ring you back. And then I have to make a note of all these patients who are calling, because in a day you'll get almost 10 to 15 calls, and it's because with different complaints. You will never know what the issue is. And then for some patients, it might be some severe condition as well. So you don't know, you can't make a decision there because you don't know what is happening there. You're completely new to it. So, and within that 2 weeks, I actually learned a lot. When patient comes up with this complaint, what are you supposed to do? What tests are you supposed to ask them? And when are they supposed to come to OPD, or when are they supposed to come to casualty, and etc. So you learn not just about the medication, but you're actually treating the patient, like with many other things, not just the medication. So that actually made it much easier for me to handle the calls or whatever when I was a clinical pharmacist here. Because when I joined, it was pretty much easier for me to set in because I knew most of the patients, because within the 2 weeks or within my 2 months posting we had during our internship. So I was familiar with at least to 10 to 20 patients I was familiar with. So I knew, okay, what is happening. So it was easier for me to settle in as well. So now if I get calls in between or anything, I don't actually have to ask consultant necessarily. Even at the middle of the night also, you get a call, 3 p.m., 2 p.m.
Yes.
Okay, this patient is having this issue. So what I'm supposed to do now? So you know an answer. You don't have to necessarily ask the query to a consultant. You don't have to wake them up in between as well, because now you are like, it's just 1 year since I started working here, but within that period, I think most of the cases you're familiar with, and you know what the patient's history is. So when he actually requires a medical attention and what is he supposed to do. So yeah, so I think I should maybe say that internship, it made a lot of difference to this thing. Yeah, so it is now easier for me to handle these situations.
Nice to hear that. That sort of interaction with the patients since the time of OPD visit until they get discharged, even after they get discharged, you keep getting the calls.
Yes.
So it is like more or less like you know the complete history in and out of the patients. So even in if you get to hear the name of the patient, you can just say what has happened since the time they had visited our hospital.
Yeah, exactly. Actually,
Can
one point I would, please go ahead, sir.
So nowadays, what happens in case sometimes they make a mistake and call me, and I'm like, okay, do something, call Dr. Harita, and then come back to me after that. So it's much more easier for that.
Yeah, actually, one point I would like to add is that most of the time, actually, most of the patients, they follow with Dr. Sudhinan sir itself. But sometimes what happens is that sir tends to take leave for a long period of time. They're like 2 weeks or 1 week, he's away, like from some kind of emergency, etc., etc. And then the other consultants will have to follow up on these patients. So whenever the other consultants see, because they're not routinely seeing this patient, so they don't know exactly why this dose was chosen for the patient, or is there any specific reason why this particular immunosuppressant is withheld for her or him, or why is the patient being treated for maybe why is he on steroids, or why is he being suspected of rejection, or is there any immunosuppressant that the patient is not supposed to take because of any side effects. So most of the time what happens is that if other consultants are seeing these patients in their OPD visits, they tend to call me, okay, come, let's start the OPD because we need to start following up on this patient. So it's easier, actually it's much more easy, because the OPD visits actually make a lot of difference, especially for transplant patients, because as I said, is immunosuppressants we are dealing with, and it's quite nasty, because sometimes a particular level, I mean, if see, for example, if I take a TAC level, for some patients we need to keep them on high level, and for some patients it might be a very low level because of one of the side effects that patient might have had. So it's not necessary that all the consultants in the department knows about this. So if there's one person who is continuously following up on that patient, it makes the job much more easier. It's not just for the consultants, but it's for the benefit of the patient as well. So I think the OPD visits has made a lot of difference in the follow-up of the patients. And it's not just something I have brought up, but all the clinical pharmacists who has joined here has started this routine, and it has definitely helped a lot in the management of the patient, I think.
Great. So this is to Sir. Sir, like what would be the consultant's perspective or the expectations from a clinical pharmacist? What do they expect? Not just in the area of transplant, otherwise as well. If what are the expectations that a consultant wise, in consultant's perspective?
So I think starting from the basics, so needless to say, they have to look at all the drug sheets, make sure that they're written correctly and that there is no repetition, reconciliation has been done. So that, of course, is the basic duty, starting with ABC. And nowadays, I think most of them is done by interns, I think. They help out with that. Another important bit is actually the discharge medication, so much of it even now with the discharge medication, because there's a lot of confusion with the medicines that they take and the medicine they prescribe, and there's so much of repetitions, and then still there is so much of generic names rather than pharmaceutical names coming in, which confuse the issue, combination of drugs, etc. So, and discharge summary being a legal document, it's a very important matter. So that is one area where they should actually concentrate a lot. So that again, it's a very, very basic duty for them. then once it goes beyond that, once they're happy, once you're okay with that, and there's a clinical pharmacist in the hospital, in your unit, then as Sarita was saying, it becomes a lot more than that. It becomes, they are an integral part of the unit where they actually interact a lot with the patients, to the point, I think now, as I was saying, when a patient is admitted as an emergency, often she knows much more about them than anybody else in the unit, because not only has she been seeing them and following them up, but perhaps in between they have been conversing as well, and she knows exactly what has been happening with them, because they would linger even if there is a cold, there is a cough, they do ring them. And I'm still amazed at how they can identify the patients who are actually sick, because whenever somebody with a fever, I suddenly think of the nastiest of things that can happen. Oh my God, he's got major sepsis, and so I either tell them, go to the next hospital. That's what I used to them. Go immediately, go to the next hospital, do the or come to the. So it does take a little bit of knack to know, what is actually serious, not serious. And then, of course, I think eventually, when it gets better and better, there could be a point where actually, manage the patients significantly and take a great load of the consultants. I think that can be happening.
Yeah, actually, there's one point I would like to add here, as I rightly said about the discharge medication. So, one thing is that most of the people actually they have a misconception that clinical pharmacists they do well only in medical departments like gastromedicine or general medicine. So they won't find much role in the surgical department. But that's actually a misconception, because in the surgical department, most of the time, the first thing is that the consultants and the PGs alike, they're all they're just swamped with a lot of work that's going on. They have to look on they are most of the time in the OT. First of all, consultants, when there's a transplant surgery going on, they just go into the OT morning and they're back only by night. So most of the time, because all the time, the time they have is only dedicated to just making sure the patient's surgical complications are not there, whether the post-op drains are okay. So a lot of their time is invested in that. So they don't get much time to look into the medications that's actually going on, and especially their past medication. So as we know, even if it's a liver transplant patient or any other patients, maybe in GI surgery also, a lot of patients, they are like admitted with some CA issues and they have to undergo major surgery. And most of these patients must be having some kind of antihypertensives or antidiabetics or a lot of any other medications. So they actually don't get a lot of time to look into it and maybe even make sure that, okay, these medicines, the patients are still receiving these medications. Most of the time it's missed out. We have had a lot of errors. We have actually encountered a lot of errors there. And then we made sure, okay, we have a reconciliation form, make use of it. Okay, so that's what we keep telling the interns, whoever are posted in our department. So they have the whole responsibility of attending the ward rounds and making sure all the patients' medications are right. So the reconciliation is the most important thing they have to do, because as I said before, the surgical department, the one thing is that you need to make sure that the medicines are there, because analgesics will be there, antibiotics will be there, but it's not necessary that their own medications, which is actually treating their comorbidities, that it's there or not, you never know. So sometimes a patient might be having, okay, he's having hypertension. So why is this patient having hypertension? Okay, was she on some antihypertensive? Okay, then why is it not restarted? Okay, restart the medication. So a lot of things that we encounter daily. So so to make sure these, we actually do need someone who is completely invested in that work. And also the discharge medication. So definitely in the discharge medication, you will see all the analgesics and painkillers, everything will be there. But okay, some patients will be given insulin for no reason, because most of the time during the surgery, we tend to convert all the antidiabetic medications to insulin, because there is a lot of risk in giving the antidiabetic medication. So what happens is that this patient may have never used insulin in his entire life, and this patient is discharged with insulin, and then he'll be like, okay, how am I supposed to take this? They might be not having any idea about it. So you need to make sure, okay, it's his own medication that we are discharging this patient with. So like this some of the few things that we need to look into. So surgical department is not something that interns can never, I mean, a clinical pharmacist has no role. It's not, it's a misconception. That's what I would like to stress here. So you need to just find a department which of your calling, and then you need to feel the responsibility. I mean, you need to do the work. You need to have a belonging feeling towards a unit, and you need to be responsible. You need to feel the responsibility, in being managing the patient. Just that's one word of advice I would like to give the budding pharmacist as well, because you just don't stay back. You need to be there even when the consultants, sometimes what happens is that we shy away. We are like, okay, let's just keep a distance, because what if they ask a question? So let's just stay away as much as possible. But you need to be part of the unit. You need to help them in maybe choosing the medication. You need to make them know your presence. Only then even you will find a belonging there. That's one thing.
Adding to
I think
that,
I'll go one step. I'll see one more step and say it's actually the surgical departments that do need the clinical pharmacists, because surgeons do not know about medications. All they know is about operate, look at the wound, take the drain out. That's it. So hypertension.
also
What is hypertension? So I think that they're much more required in the surgical departments than in medical departments, because the medical department they do only medicines. The surgeons medicines, they're not required. So
and the rounds, the medical departments,
nobody
their rounds
ever
are
looks
also
at the medicines. Nobody ever looks at the medicines. So only look at the drain, trials tape, how's the wound, and then hi, that's it.
Yeah, that's exactly what happens, because it's like a lightning round. The consultant come, they're like, okay, 1 to 2 minutes, how are you doing? Do you have any pain? Okay, fine, good to go. We'll discharge you in 2 or 3 days. But when you take the
how's the bowel sound?
How are the bowel sound? Yeah. But the medical rounds, if you see like 1 or 3 hours, maybe it just goes on and on and on. During my internship, I was like, okay, why is this not ending? I need to take my lunch.
Patient comes up with again a new complaint.
Yeah.
So adding to that, even what we have observed in the transplant patients is the anticoagulants. So they come with anticoagulant when it is supposed to be stopped. So they stop it prior to the admission, and nobody bothers when it is supposed to be started. So intervening in the discharge medications, as you've told, so it is the most important thing when it is supposed to be restarted, because they also have comorbids that we have to worry about.
Exactly.
So we cannot expect a surgeon to look into all these details about the medications as well, because it is a huge burden, I feel, on the surgeons as well. Since the time of transplant until the patient gets discharged, they'll have to look into multiple things, the surgical site infections being the huge burden. So I think adding a clinical pharmacist to the surgeon's team would be a great addition. As Dr. Sudhindran has also mentioned, it is great to hear from consultants like this, surgeons like this, that adding a clinical pharmacist to the team had added a value. So it is great to hear that. So
indispensable. Indispensable, you guys are.
So, as Dr. Harita has mentioned, the challenges that you have mentioned, fitting into the shoe. And to that, are there any other challenges that you've faced since the time that you've started working as a transplant clinical pharmacist?
That itself was a huge challenge for me, because the initial days as a clinical pharmacist was really, because it has actually taken off my sleep, I should say, because there's only one clinical pharmacist here in this department, so you have the entire responsibility of managing the patient. So usually our day, what our roles are is basically it starts off with the ICU rounds. So you need to be there in the ICU during the consultant rounds, and then after that you come to OPD during your OPD days, and then you need to manage the OPD patients, and then at the same time there are discharges that is happening in the wards as well. So you need to cross check, because the interns have the responsibility of adding the medications and cross checking that, but they need an assurance from our side as well whether it's right or not. So simultaneously you are like constantly checking onto that
juggling
as well, because juggling in between a lot of works. You have to your brain has to multitask. So there's one patient sitting right in front of you in the OPD, and then we are treating a entirely different case, and then simultaneously you're getting the message from the interns may be, okay, so this patient is getting discharged, this patient is on this medication, but now what should we do? Should we add that? Okay, now the second query will be, okay, this patient has a culture positive, so he was getting this IV antibiotic, it's only day 3, so what should we be, what should it be converted to, what oral medication should it be converted to? So you have a lot of things that is going on, and initial 1 to 2 weeks was for me like was a roller coaster, right? Should I say? It was like, okay, what am I supposed to do? Okay, calm yourself, calm yourself. And then I had to ask my previous clinical pharmacist as well, okay, so what I'm supposed to do, because it's not possible for you to actually know what this patient's condition is, because she must be having the correct follow-up of the patient. So it was definitely one big challenge for me. And then also the follow-up of the patients as well, because so now you're seeing, because for me, that was my just first posting. After that, a lot of things has happened here. A lot of new patients have done their transplant and now they're following up. So you have this on-call phone with you. So this patient is calling up and asking you, okay, so I called you last day and I had these complaints. You asked me to take this medicine. Now I'm still not feeling good. Now what medicine should I take? So I'm like, okay, so yesterday you called someone else. Now this is no longer the same person. So I have no idea what to do there. And yeah, so initial 2 weeks you don't know, so you have to ask consultants help as well. In as I said, I mean, initial times, like I had to ask the doctors and I had to ask the particular consultant, okay, what am I supposed to do, this patient has this issue. So it was actually a tedious task. And then eventually, but yeah, that challenges where somehow I overcame it with the help of the consultants, obviously, and with the help of my past clinical pharmacist. She helped me a lot through this phase, actually, and also the other staff as well. So it was yeah, that was 2 other challenges that I had to face. And even in the ICU setting also, because it's not just a ward and OPD visits, okay, we can manage because we have other PGs. When we in the OPD visits also, it's okay because the consultant is right next to you, you can just ask them directly. But the ICU thing is that there are a lot of more complications, post-op complications that we are looking into, and a lot of other surgical infections. We need to assist them in choosing the right antibiotic also, and the dose adjustments. That's the most important part. So initially, the immediate post-op, post-transplant patients, most of the time, the creatinine tends to rearrange. Sometimes the patients may go into dialysis as well. So you need to so what these consultants do is that they just write down the medicine. They write the medicine name. They're good at that. They write the medicine then. Then they just turn around to the clinical pharmacist. They're like, okay, what is the dose now? You calculate and tell me. So I'm like, okay, I'll do that. And then they reach the next patient. They ask the same question. So okay, let me just finish this work first. So a lot of patients there in the ICU. You need to select the appropriate dose. It's your responsibility of doing that. They won't be. I mean,
we're not doing that because we don't know how to do it. It's because it's impossible for us to do it. We can't do it. It's the biggest mystery for us. How does a clinical pharmacist sort it out? Somebody on CRRT, I mean, how the hell do you know what dose to give? Sorry, it's your job.
Yeah,
we can't do it. It's impossible.
They just turn around and they ask.
It's like E is equal to MC squared for us. It's an Einstein thing for us. Too much of rocket science.
Yeah. So yeah, that was the challenges that I had to do. I mean, that I had to face initially. But now, if you ask me, it's become really smooth. I mean, because it's more easier now. So once you start working there, you become part of the unit and you face the situations on a daily to daily basis. Then you just know it by heart. So you don't have to look into any other thing. You don't need to calculate. You just know it by heart and you just start writing it off very easily. So it's just the beginning thing that you need to. But you should feel disheartened with that. That's one thing that I've learned. You just don't give up when you feel stressed or when you feel that you're overworked. That is just the initial phase, and then something it just goes on smoothly. So yeah. But now it's not. I'm not saying that there are no more challenges. There are definitely. Each and every patient comes up with a different challenge itself. But you get to learn every day because of that. And then when some other patient come up with a similar complaint, you can easily manage that situation. So
with us in our hospital, like even the transplant surgeons for that matter, surgeons have their huge team, but there are few queries that we get that the surgeon is only supposed to answer or take a call on that. So surgeon will be in the OT, busy in surgeries, and we keep calling them because we need an answer to help the patient, or the patient or the attenders will come up and then keep asking questions. So how is that for you, sir? To get calls in middle of your surgery, and how is it difficult, or is it like now it has been like a journey for you? Is it like a cakewalk?
No, I think the initial years it was difficult because there's not many people who could be. I mean, when you set up the unit, a lot of them are not used to transplant scenario because we actually started the liver transplant at Amrita in Kerala itself. So not many were used to it. So those periods where, I mean, it was difficult in the sense, throughout 24 hours you had to be on your toes. But I mean, you've come a long way of that now, and now there are so many people there. So the teamwork is there. I think one of the most important thing in any big units is to get your teamwork.
Yes.
So
Definitely.
yeah. So once that is there, I think you're okay because it's a equal sharing with everyone. So I think that has been okay. I mean, I don't think either will find that difficult because if I'm not there, somebody else is there. Somebody else is there. So and nobody's missed. So everybody is important, but nobody's indispensable.
So like coming back to the conversation, like we have discussed what are the roles and responsibilities that a clinical pharmacist can add on to the role. But are there any new initiatives, or are there any roles that we can add on to the existing things for better quality care?
If you ask
is that to me or
yeah,
okay? Yeah,
For
go
both
on.
of you.
Yeah.
for both of you. Okay, actually, sir, you can start off with that if you want. I can
You
take
start
over.
off. Yeah.
Okay, so if you ask me from a CP point of view, I think, see, for the work we do now is basically we assist the consultants. If it's in the OPD basis, obviously it's just assisting the consultants. We'll be there along with the consultant when the patient comes in. Even a new case or even a transplant patient, and then we'll be looking into the labs, and we'll just make sure, okay, the dose are adjusted rightly, and then the medications are appropriate. Any other medication that is to be tapered off, we'll do that, or any other supplements that patient requires, we'll make sure it's added on or not. And then we also decide on the next follow-up visit, and what all tests to be done. A lot of other things that has to be looked into. It's very imperative for these transplant patients. So yeah, as I said, it's basically assisting the consultants. But I think when once you gain more experience, and once you know how you actually approach a case and how you follow up on that case, there will be a point where you will be able to do it individually. Like, you don't have to entirely a patient entirely doesn't have to depend on a consultant alone. Maybe they can just see the clinical pharmacist, because at the end of the day, it's about the medication, about the immunosuppressants. So that's something that we need to be aware about, and we need to learn about on how to rightly adjust the dose, how to properly maintain the immunosuppression, so that they don't end up getting the rejection complication or any of that sort. So I think once you gain that experience, maybe when an initiative where clinical pharmacists see the post-op patients might be a very good thing, because it will be very easier because it's basically reducing the load of the consultants as well. Because here what happens is that most of the time, because the patient have to end up waiting a lot for the consultant to start the OPD, because see, they are surgeons after all. They have cases that's running in the OR. They have to juggle between a lot of works. So maybe it will be like afternoon or maybe noon by the time the OPD starts, and all these patients, especially the immediate post-op patients, they're not that well. They're not that. They have. I mean, they're still weak. They have a lot of issues going on. So it's difficult for them as well to wait for the consultants to come and give the medication, etc., etc. So if there is an initiative where we actually start, because I think in abroad also there's I mean, as we all know, because where the clinical pharmacists, they have the authority, or they are very well trained as to handle these situations. So if we have that as well in here in India, then that would be a really good initiative. That's what I feel. So it will be good for the transplantation as well, because they are following up with me as it is via the phone or whatever. So I mean, it will be easier for the patient and for the consultant as well to keep a regular follow up on the patient. So I don't know when that's going to happen, but I think in near future maybe we can maybe expect that somehow we can make sure that happens. Yeah. Maybe over to you, sir. Do you have any other input?
Yeah. No, I think a couple of things. One is, as I alluded to earlier, and as I was also mentioning, I think the role of a clinical pharmacist is probably much more stronger in the surgical departments than in the medical department because of the stress that the surgeons have on the non-medical things. They're more interested in doing the surgeries or posting the patient to surgery, looking at the need for surgery, what surgery. There's so many other things they have to do. So in the midst of that, the medicines and things which take a second, which shouldn't. So there, I think the clinical pharmacist takes a huge role. So it is not just about adjusting medicines, so it's making that clinical decision, so, and that can be a huge help. So, looking at the thing and looking at the results and analyzing what it is it a rejection? Is it an infection? What should I do? That sort of thing. In a surgical department, that it's very, very crucial because particularly in India, interestingly, the liver transplant, kidney transplant is a little bit different because the nephrologists look at that. But liver transplantation, they're predominantly looked at by the surgeons, particularly the initial part. And there, I think the clinical pharmacist role is huge because there is no actual physician, looking at these things. So that's one thing, they're looking at the clinical thing. But second, what's very, very important, I think maybe I'm just diverging from the topic a little bit because when you say that the name clinical pharmacist, it means clinical. But I think, it needs to be a clinical research pharmacist because the research stress on the clinical pharmacist is very, very low. India is one country where there's no research is done, particularly for new drugs, etc. Our clinical load is huge. And based on the clinical load, when have you ever made a new drug in this world? We haven't.
Yeah.
It's up to us to do that. We need to do it. And it's the clinical pharmacist who will be the predominant link between that lab thing and the clinical thing where it needs to happen. So that research importance has to be stressed from your point. I mean, sadly, because there is no money in research, it doesn't come up. So, but eventually, I think it will slowly take that place. We need to be a country where we should be making new medicines, new drugs, etc. So, the clinical pharmacist terminology has to be changed, I think.
Yes, sir. Definitely, the research part is not like how we see in abroad. Even on the new drugs that we start to use, there are not much of a research that is being conducted. We sort of like rely on the abroad research papers, and the patient setting that they consider is very different from our patient setting. So to relate those kind of things and like apply it on our patient population is also like sort of a little difficult. So it would be great if the research things have like increased, as like adding clinical pharmacist as well into that would be a great change. That's what I
Yeah,
feel.
as you rightfully said, because sir has been bugging me about that for days and years and months now.
Yeah.
about writing a paper and publishing it. But yeah, actually it's actually quite important because it's not just about doing a work. You need to make sure that your work is recognized as well. And that one thing is, one way of doing it is that by publishing what you're doing actually. So once you find an intervention, maybe you can publish a case report. That's also fine. But yeah, maybe looking into the medications, how it has actually changed the patient management. That's also important because it's not just helping you getting recognized, but
it
it's also
reaches
help.
out
Yeah,
as
it
well.
reaches out and it will help the other consultants or other clinical pharmacists as well, and it actually motivates them as well to take up the job or take up a research paper or in many other ways actually. So that's one thing one must be focusing on. Most of the time what happens is that during our even though during our course we have this thesis publication that is mandatory, we just focus on, okay, since it's mandatory, since we need a certificate, we are just doing it. But I think we need to start thinking differently and focus more on the research paper, because that's one way of learning as well, because you're looking into a lot of articles, you're learning their ways, their method of approaching a case, their way of treating a patient, and you can actually apply to your patient. It might make a lot of difference. So yeah, definitely writing a research paper, doing a research work, and reading other articles, that's one thing that's very important, even as a CP, not just for the MBBS doctors or anyone, even as a clinical pharmacist point of view, it's very important. So you can make a better decision in patient care.
Yeah.
Yeah.
So having said that, like we had a conversation about your journey, how it is started. Even like I would want to also ask how it is like actually started. Joining the transplant clinical pharmacy and joining the surgeons team. That idea, how did it even start?
So actually, that started when I was my fifth year. When actually, so as I said, we during our PharmD we have it's mandatory for us to release a thesis. We need to do a publication. So I approached sir. I mean, we looked into a lot of departments, but nothing was very interesting. And then somehow we ended up in GI surgery. We asked sir for a project. What can we look into? And then sir came up with the transplant patient follow up. Basically, the rejection is one complication that any transplant patients can encounter in their lifetime. So just look into the transplant patient, the patients who had rejection, and then to identify the risk factors, and based on that, how can we modify the immunosuppression, or how can we manage that protocol? Can we come up with a protocol for these particular patients, or is there something that we can look into? So that was our topic during our fifth year. And then, so initially, again, that was a challenge because sir was saying something like about tacrolimus, severolimus, you need to look at the liver biopsy post transplant. And for me, these were Greek, Greek words I was listening into. So I was like, okay, I have no clue what you're saying. Let me take a look into it. And then we start reading, and then we come to know, okay, so the transplant patients, they have quite a complex, because it's just your fifth year. You don't know what happens during a liver transplant, what medications these patients are supposed to take. You don't know because you just started your clinical postings there. So that's how I started learning. And then thankfully I got my posting also in GI surgery, and then you understand more about it. So even during my PharmD internship, my first posting was in GI surgery, and then I took a look and I was like, okay, so there are a lot of surgical patients, and some patients are receiving some medication, some are not. Something or the other is happening. I mean, it was very tough for me because just I'm just an intern there, and yeah, I had no idea of what the case was. Why is this patient here? Why are we doing this case? So what medication should we ensure? So it's like it's very new to you. And then somehow you get the idea of it, and then you understand, okay, there are a lot of things that you can actually do here. So that's the first posting, and you're like all enthusiastic. You need to show your you need to do your 100%. You need to prove them, you need to tell them that, okay, a clinical pharmacist can make about a difference there. So that's what I did during my first posting in GI surgery. I was like all enthusiastic. I wanted to do something. So I looked into I go around to the patients, I talk to them, I ask them what the medications are, and I just basically I just talk to them. And then I make sure the reconciliation forms are filled, because this was strictly told by our clinical pharmacist, that was Nafia. She told us that, okay, strictly you need to do all these works, and you need to look into the discharge medications also. It's very important. So I did all that. And one drawback of being in a surgical department is that you never get to attend the consultant rounds, because they come in whenever they can come on like whenever they want, because it's because they've stuck, as I said, they're in the OR. So maybe the rounds will happen at 6 p.m. or 8 p.m. The consultants will be coming and seeing the patient. So all you get to do is a PG round. So you can attend the rounds with the PG, so you'll get to know what the case is, and you'll get some idea. And then somehow, with all this 2 months of posting was over, and then I was like, okay, I don't want to leave the department, because you're doing something here. Because by the end, the PGs, even though you're an intern, the PG started asking you all the queries. Okay, this patient has this concern, so what am I supposed to do? Or the PG start asking you, are you sure you cross check the discharge medications, because I need to approve you. Did you did you check or not? You check? No, then I'll approve. So you get the feeling of being responsible there. You started feeling belonging to the unit. You feel that, okay, you are needed there. You can make a difference if you actually work for it, or if you actually think about it, you can actually make a difference. So I was just but it was like my posting were I mean, it was like coming to an end, and then I just need to talk to someone about this. So I middle of the night, I just sent a mail to my consultant. I'm like, okay, thank you so much for the posting. I had a good time here. But just few things that I encountered during my posting, and I think that there are some works that we can be entrusted with, and I think I just want you to notice those. So I just I just mentioned few points, that what are the different works we can do. Just just making sure that the consultants know. so that next time when someone comes up, you at least make sure this work is being done by them. Just recognize the pharmacy interns that's there.
Yeah.
And then I did that, and then that's how I think that just got circulated in the department, and then the consultants came to know about it. So that made easier for the other pharmacists as well. So yeah, it was initially, it was a challenge working in a surgical department. Initially it was definitely, because as I said, there are no consultants there, so you need to learn by yourself. You can't expect someone else to teach you, this is this case, this is this thing. You need to take the time out, you need to learn about each and everything, you need to know why this medicine is done or why the surgery is done, and you need to learn it by yourself. So initially it is a challenging thing, and also talking with the consultants as well, because you rarely get to see them. Once in a while you get to see them, and you have to talk to them about your intervention. So initially, even though it's a challenge, but then, as I said, you just get used to it. Then it's a cakewalk basically.
Yeah.
So yeah, that's what I would say.
Yeah, I think I have to intervene and say that email, Haridha, I think it made a huge difference, because till then the pharmacy interns or whatever, they used to come there, and then they will be there because somebody will come and introduce and say, okay, these are the interns. But then they just used to be there, and the active participation somehow was not coming up. Because even the consultants or the PGs, okay, it was just a help, that is it. But then once the letter came, then we realized, that was a very unselfish and a responsible and a conscientious thing to do, Harita. Because her posting was finished. It's for the subsequent batches. And then suddenly, it's a lot of things dawned on us. Okay, this is what all this has to be done. And then subsequently, there's so much that now they make topic presentations, and the individual duties given to them, and everybody now knows them after that. It was a while ago, but still, so such thing have made a huge difference in being part of that unit, as you keep on saying, which is a crucial thing. Otherwise, they just come and stand by the side, do it around. If they come, they come. They don't come, they don't come. So that has changed a lot. Thank you, Erika, for that.
Thanks to the other clinical pharmacists that way. They helped me a lot.
Who had laid the path.
Yeah. I was just making sure that at least the interns' work get recognized, because the clinical pharmacist, obviously, so no, all the department knows, but what the interns are doing, they were a bit unaware of. So I just wanted to make sure that at least, we are being a part of it. We are actually being recognized. So, and also that's one way how we can learn as well, because most of the time during the rounds, they do ask questions to the PGs and even the MBBS interns also. They do ask all the questions to them. So we feel left out. We are standing there, but you guys are not asking us any question, because you don't know. Okay, sorry, we are family interns. You can ask us about medication. I know it's a pretty much, maybe we are like, okay, don't ask me a question. I don't know the answer. We might feel shy. We might, step back. But actually, that's another thing that I would like to say, that you don't have to step back. Actually, you need to stay there. You need to listen to the question, even though you cannot answer. It's okay. You're just an intern.
That's how we learn as well.
That's how we learn, because you go back and you make sure at least next time we don't have this this same situation. Next time you need to make sure I answer that question. So that's how you learn, actually. So you should never shy back. You should be there. The consultants or whoever that is, they should know your presence. Only that's how you can actually make a difference as an intern, also as a clinical pharmacist or whatever that is. If they have to feel your presence, you need to make them aware of your presence. So that's how you can do it.
Yeah. So as you've mentioned that you have got this idea when you were doing your fifth year graduate program. So what would be your suggestions for for the graduate students if they want to pursue in transplant department? What would be your suggestions for them that they should be prepped up with?
Yeah, so preparation is actually it's the same. It's the same for all the departments, because whenever you plan of working in a certain departments, there's something that you need to know, the basics you need to know. What are the cases? It's not just about the medicines you need to be learning, but what cases are we encountering on a daily to daily basis? What surgery, what complications are to be expected? And then comes the medications. So only when you know what the case is, or only when you know the diagnosis, you can treat the patient, right? So if you are planning to take up transplant, or if you're planning to take up any surgical department, you need to make sure that you know what the case is. you need to go to your really basic. You need to learn the medical stuff as well. It's not just the medication or PharmD thing that you have learned over the 6-year course. That's not the thing. So yeah, again, it's not the theory thing that applies here when you become a clinical pharmacist in the hospital, because theory and practical, the practice setting is completely different. So you need to actually learn more about it. And if you're asking about the transplant, yeah, definitely you need to know how the patient end up in a transplant. So if you're taking into a cirrhotic patient, so what are the causes of it? How do we treat, how do we actually manage cirrhosis patient? There's a pre-transplant phase where they have to be given a lot of medications. They have a lot of complications, a lot of decompensations they are facing. So how you address individual decompensation, how you treat them, how you're supposed to follow up on that patient, right from the basics, you need to be very clear on. So if you're aspiring to be a clinical pharmacist or in transplant, then that's your start away. So you need to focus on your gastro medicine posting. Again, that's one thing also, because your gastro medicine deals with all these patients. Even we do, but most of these patients are there in the gastro medicine. So yeah, so you need to know the basics there, and you need to know the medications as well. As just like you need to know the cases, you need to know the medication, why they're to be given, and especially the side effects. That's one important thing. Most of the time we learn about the mechanism of action because we expect all of them to ask you this question. Okay, what is the mechanism of action? What is the mechanism of action? But more important is the side effect profile of that medicine. Because only when you know the side effect profile, you can actually manage that particular manage that effect the patient is having. Because if the patient is somehow having the toxicity, you need to know how to manage it. So and you need to know what is actually causing it. Only then you can treat the patient. So it's very important in that way. And one more point I would like to add here is that I think in FCPI, we have a lot of other forums we have already launched here. And I think, we are actually trying to initiate a transplant forum as well. And hopefully it will be released next year. So if anyone who is aspiring to a transplant pharmacist, you should definitely stay tuned for that, because it's not just about the medication or the transplant pharmacist thing, but we'll be trying to include all the basic stuff as well, as in how to manage the organ failure patients, how you approach the case, what are the pre-transplant workup things that are very imperative, how you manage the post-operative patients. So I think the FCPI could be could be a great platform for those budding clinical pharmacists as well, who's aspiring to be a transplant pharmacist someday.
So, sir, what would be your inputs or suggestions for the graduate students?
Is that for me?
Yes, sir.
Yeah, I think most importantly, I don't think that first of all you should consider yourself as the second gear to the MBBS students at all by any means. Not at all. You don't have to. That is very, very crucial, because you're right up there.
Yes.
So, and it's important to feel that way. Otherwise, you take a second step in all the things. Okay, don't do that, please. You're very important. You can do a lot, and so you need to feel that in your thing. Okay. So I think that's the number one thing. Second, I think the future clinical pharmacist is very, very bright in India. So you've taken a good path.
Thank you, sir. Thank you.
Yeah, most of the time that PharmD graduates, they end up thinking that, okay, so we don't have much roles here. Our role is only abroad. So you need to work. They go abroad. They need to do a lot of course work there, and then only they can practice. Only then they get the license there, and then they get to practice there. So I think that thought should be also. It should be changed. I think, because it's not like there are no roles here. If you look for it, if you actually work for it, you can actually find a role here itself in India, because the situation has totally changed from what it has been before. It's not like 1990s or anything. The year has totally changed, the era has changed, and now they're actually, a lot of consultants are actually looking up for this clinical pharmacist, because their role has actually made a difference in a lot of things, in patient care, in OPD visits, a lot of different arenas where clinical pharmacist has actually made a difference. Not just clinical pharmacists, even the interns. If you take our hospital, the interns are actually a part of all the major, the departments. Most of the departments, they are actually assisting the consultants, and they actually get benefited out of it. So So I don't think they should actually think that, okay, our roles are not there in India. The clinical pharmacist roles are only in abroad and we have to go there. All the students tend to do that. So I think that thought process should change a bit. Maybe you need to look into and you need to feel, I mean, as sir rightly said, if you actually are looking into working as a pharmacist there, you need to be a part of the unit. You need to feel that belonging thing. So it's very important. Just don't shy away, or don't think that, okay, maybe my presence is unnecessary here. I'm not useful here. Maybe I should go somewhere else. But actually, in all the departments, we all have roles. Just that we are not working hard towards it. We need to work towards it. Only then you can expect the others to look into it and make see that as well. So that's one thing that I would like to say to tell the interns and the pharmacists.
Yeah. So I hope the audience have got a lot of inputs, and as we have unleashed the transplant clinical pharmacist roles and responsibilities, there will be a lot of graduates who would be interested to join the transplant departments as well. All right, we have reached the end of the conversation for today's episode. Thanks all for tuning into today's episode. I am extremely thankful to our guests, Dr. Sudhindran and Dr. Harita, for sharing the valuable insights on roles and responsibilities on transplant clinical pharmacists in India.
Thank you so much. The honor was entirely mine.
Yeah, thank you so much, Nisla.
Thank you
for
Dr.
this opportunity. Thanks.
Thank you. Thank you to each one of you listening to the podcast this evening, and keep supporting the FCPI forum events. Thank you.
Thank you.
Good day.
Good day.
Yeah.